Happy holidays from Wheatie. I'm Michael McNutt, Wheatie's Director of Education and Events, and it's my pleasure to welcome you to the Health Plan's Guide to Interoperability in 2024 and Beyond, presented by Cohere Health. Allow me to introduce today's presenters, Niall O'Connor, Chief Technology Officer, and Jason Amaral, Engineering Operations Manager, both with Cohere Health.
Good afternoon, everybody, and thank you for your time this afternoon. Myself and Jason will be taking you through this presentation, and Jason will be driving the slides. So Jason, can you go to the next slide, please? So we'll go through a little bit about Cohere and about how we were founded and our kind of founding philosophy and what we're trying to achieve. Interoperability is a major aspect of that and a major aspect of this community, and we wish to kind of give you our perspective on it and how to drive automation in the modern era with technology and artificial intelligence. We'll go through some of those strategies and finally wrap up with some insights on how interoperability can help drive better clinical decision making. So my name is Niall O'Connor. I'm the Chief Technology Officer at Cohere. Jason, do you want to introduce yourself?
Yeah, hello everybody. My name is Jason Amaral. I'm the Engineering Operations Manager here at Cohere, and one of my roles is leading our interoperability business unit.
So Cohere was founded a little over 4 years ago, and it was really born out of a belief that we can use technology to remove a lot of the administrative burden that both providers and health plans suffer from over the course of doing business. Prior authorization is an area in which we have focused on initially, but there is a multitude of different areas where we believe that technology well applied and with the use of modern practices in AI and artificial intelligence, we can really drive best practices in both clinical care and a better experience for patients. Our company is physician-led, and that also has led us to take a posture in which we believe that as a prior authorization company, we should be extremely transparent and timely with their decisions. And that really you'll see as a thread throughout this. We've from the early days of the founding of the company, we've adopted interoperability standards to encourage the timely conveyance of both administrative data and clinical data for the purposes of turning around decisions instantaneously. Being a physician-like company, we have a large clinical staff which help us tailor our automation to be sensitive to the clinical context, which we believe to be important in driving high rates of automation, but also high quality decision making. Since our beginnings about 4 years ago, we are at a national scale and across a broad reach of clinical categories. Next slide. So just to dive in a little bit more on that national scale, we're in all 50 states. We serve about 17 million lives across both commercial and Medicare lines of business. We manage about $6 billion in medical expense and process just shy of 6 million authorizations annually. Really, some of the kind of key aspects of what we think we offer is that our solution, again, is favorable towards providers. Providers like using it. We've got reasonably high net promoter score amongst providers of 61, which is really unheard of outside of kind of consumer level web applications. That has led to a strong digital adoption. So most of the provider community that we serve communicate with us over digital channels. So that's either electronic medical record or our web portal, and so very few of it is coming through either phone or fax. One of the key aspects of our approach is that we are transparent throughout the auth submission process, and that leads us to achieve medical incremental medical savings without the use of denials. And so as a user is using Cohere, we are nudging them or informing them of the most appropriate configuration of that request, such that it will get a timely response, or indeed in a lot of scenarios an auto approval. And so that ultimately leads to about 70% faster access to care. And we've been able to measure that across a variety of different lines of business and clinical areas. Next slide.
Great.
So Jason, do you want to take us through some of the interoperability aspects of this presentation?
Yeah, happy to. So a lot of those sort of key metrics that you saw there are enabled through interoperability. And since our founding, a lot of our interoperability standards and approach has been driven by upcoming regulation or governmental sort of standards that are being set. And we see this ongoing at both the state and federal level. Examples in both Texas and California around prior authorization legislation have been continuing. And then one of the more recent examples that is not on here is Washington State's sort of very tight turnaround times around prior authorization. So the technology around interoperability and a lot of the metrics that Niall was going through is really sort of facilitating and adhering to the standards that we are seeing regulators kind of start to implement. All of that success is largely enabled through our main kind of methods of interoperability. So we were, as we mentioned, we were founded early on within sort of the framework of the HL7 DaVinci working group. The three components of DaVinci are all solutions that we have implemented to date, and are very proud of sort of the success that we've achieved with some of the submission of prior authorizations, the simple requirements discovery of whether or not a prior authorization is required, and the management of those requirements at the payer level. And then finally, an area that we're most excited about is sort of starting to document more clinical interaction and leveraging that machine learning and AI that Niall alluded to have a very sort of keen response on what documentation is required and how we can and cannot retrieve that from a given source. We believe that those types of interactions have led and will continue to drive our auto approval rate, as well as the very quick turnaround times that users are used to now experiencing on Cohere. And that's achieved through that transparent method of data through our authorization process and our management of the complex rules and requirements that each payer has. And lastly, through sort of a method of accountability, we publish the prior authorization list from our given payers and maintain those through sort of quarterly updates with through reporting and our sort of regular maintenance with our payers. Strategically, the way that we enable our interoperability is through partnerships. So we encourage collaboration through data aggregators, through EHRs, through any sort of partner system that will help us and other payers achieve their goals of prior authorization that is less cumbersome and more streamlined. And ultimately, the end user who are serving are those hospitals and health systems who are submitting prior authorizations and kind of going through the submission process to get their decisions on prior authorization. So we believe that championing those providers, working very closely with our provider success organization, leveraging sort of our high net promoter score to continue to develop our application and leverage the technology behind it, enables that partnership that has led to our performance so far. And what you're seeing here on this slide is sort of just an initial touch point or a moment of influence that we have with the user at Cohere. So as I mentioned, the providers and their sort of health system users interact with Cohere in a number of ways, but there are moments in our prior auth submission experience where we sort of are able to nudge them in a specific direction. We believe that the influence that we can have on these crucial moments of decision during prior auth submission only sort of enhances our prior authorization process, and that combined with our interoperability gives them the experience that is truly a standout experience. Now I'm going to walk you through a little bit of that decisioning and sort of how we leverage our machine learning and AI to get to that point.
So one thing we want to be kind of clear about, what we hope you will take away from this presentation, is interoperability is part of burden reduction, right? As over the course of how you submit a prior auth, there are a number of human touches, whether it's population of the administrative data that goes along with the prior authorization, or selecting for the appropriate clinical information and conveying that to Cohere. And interoperability can play a role in hastening the transfer of those data. But what's crucially important is that you're actually able to automate the clinical decision. And whether the information comes to Cohere, whether through the phone or the fax or the portal or an EMR, we at an operational level and a decision engine level have to be incredibly sensitive to the clinical context that's applied to the case. And so some of the burden reduction comes at the very start of the process, and Cohere have a utility utilizing the coverage requirements API as outlined and spec'd by DaVinci to do a prior auth check. So at the very start of the process, we can check the prior auth and the network, incorporating all the payer rules that drive that, so that at an EMR level, a provider doesn't have to even submit an authorization if we can tell them in advance that that either this procedure or the network in which this provider is operating in is excluded from prior auth as per the plan payment rules. And assuming that a prior auth is required, then we'll take the necessary information. And again, we'll try to do an early yes as often as possible. So there are times where if a procedure is reasonably routine and it is really predicated on having a certain gap in care or time since the previous instance of this procedure, we can make a timely decision without even requesting clinicals. An example of this might be certain pain injections or physical therapy appointments that require certain spacing. And so just based off the administrative information, we can often just approve a case early in the process. Assuming then that we can't do that, we then have to look at the clinical information. And so, in a couple of slides' time, we'll go through this in a little bit more detail. But this is where we start to look at the totality of information that's available to us, whether that is prior claims data or the clinical documentation itself. We use the best of breed natural language processing and a lot of the more modern large language models to search and extract and transform key pieces of information out of clinical notes, which are fed directly into our rule system. Lastly, if we cannot automatically approve a case, that will go into a review queue, and we have technology that enables faster reviews, but also a higher quality review by guiding the clinical reviewer to the various aspects of the case that either failed a particular rule on our side, or there was some missing information. Next slide, Jason. So part of that advanced decisioning that I mentioned involves a variety of different techniques. So whether it's machine learning driven note extraction, or some aspect about the patient history, or some explicit plan policy rules, or rules that we have about providers, both on the quality side and also contract side with payers. And then lastly, predictive rules. These are all configurable in our rules engine. And our rules engine is built specifically for this purpose. We don't have a generic rules engine giving us generic answers. These are all tailored for the purposes of driving automated clinical decision making in prior auth. And we can, as we engage with plans, we can customize these rule sets very quickly and with a high degree of accuracy. There's a lot of analytics to back up each and every clinical decision we're making, and we can view that at a plan level, line of business level, provider level, market level, and there's a lot that goes behind this advanced decisioning engine. Next slide, Jason. So I'll just speak a little bit about kind of our philosophy on how we apply different layers of intelligence when it comes to making clinical decisions. And so when we look at the market in general for prior authorization automation, there's still a lot of plans out there that are at level 0. So 100% of inbound requests are either sent through the phone or the fax machine, and each one of those are manually reviewed. And then level 1 is where a lot of plans get to early in their journey for automation, where they'll apply something like a clinical questionnaire, and then they'll drive rules directly based off that clinical questionnaire. Now, some of the challenges that we've encountered with these approaches is the individual at the practice level filling out these questionnaires isn't a clinician, or they don't have the necessary information available to them so that they can answer the questions accurately. And so what this leads to is both false approvals, as in due to inaccurate answers, we are approving the case inappropriately using automation rules, or it's false pens leading to delays in care and higher administrative costs for the plan. So when Cohere started to innovate in this space, this is precisely some of the concerns that we had and some of the challenges we sought to solve. And we moved to what we called a number of years ago as level 2, where we're using claims look back and also clinical note extraction to pull out key pieces of information that allow us to approve or pen a case. The challenge with some of these level 2 rules is that they're reasonably expensive to write and to analyze. So we've trained analysts that work at Cohere that are continually refining and trying to find pockets of cases that could be automatically adjudicated. And one of the challenges is that you don't have comprehensive information on every member. And so there are times where a member might have a very short claims history. They've just joined the plan, for instance, or the practice that we're dealing with hasn't provided the necessary documentation or any documentation. And so to counteract those limitations, what we start to develop are what we call level 3 rules. And this is really signals-based intelligence, right? So we're looking at qualities that we know of the member, the history, if they have a decent history, but more often it's looking at past practicing patterns of the provider and seeing, in general, does this provider allow or do something that's in accordance with guidelines most of the time. And so this is a really a kind of a statistical judgment that we're making about this case. So for this case, for a patient like this, does the provider typically do the right thing? And that allows us to apply a score comprehensively to every single case and use that in conjunction with level 2 in our decision making. And when we do that, we get to quite high levels of automation. And that's where you can start to see in some clinical categories 85 to 95% automation of the clinical decision making, with a high degree of accuracy and an explainable decision on each result. At level 4, then, this is somewhere we're quite active in, and it's very relevant to areas where the clinical guidelines are quite general or quite broad and don't apply a lot of cohorting or stratification of a given population. And so in level 4, what we're trying to understand is, does a given clinical procedure, even if it meets the letter of the guidelines, is it still the most optimal instance of care for this member? And so examples of this are in things like spinal cord stimulators. There's a very, very high revision rate of those procedures, and we've been able to develop predictive models of when they work and when they don't. And this is a moment of influence, as Jason was outlining earlier on, where we can prompt the user, or even through a peer-to-peer consult, advise the practicing physician of the kind of expectation of efficacy of a given clinical procedure. And this allows us to drive incremental medical expense savings, avoiding costly procedures that have low efficacy or generally just low quality care. So all of this is really party to the interoperability story. So you can move data around, but unless you're able to use it in these increasing layers of sophistication, you're really not maximizing a lot of the work that's going into interoperability. So next slide, Jason. And so just lastly, just to kind of summarize, the engine and the approach that we've taken really is sensitive to both the provider context and the specific clinical context that the patient is experiencing. This allows us to provide a lot of kind of interesting metrics back to the provider population. One of the other ways that we are able to influence our network is to be able to give them context on how they are practicing with respect to their peers and respect to other specialties that might be comparable. And a lot of these metrics give it insights into the provider if they're able to be greenlit for given procedures in light of the fact that they more often than not are practicing within guidelines. And then lastly, some of these techniques allow us to more intelligently route patients to clinical care management teams. Next slide. So with all that, I think we'd like to open it up to some questions and answers.
Jason, Niall, thank you very much. We welcome questions in the chat. In the meantime, I have a couple of questions for you. How do you think AI will change prior authorization and over the next few years?
Yeah, so I mean, I think it's already changing utilization management. I think AI, especially the more modern generative AI, is really most appropriate for administrative type tasks. If you think about utilization management, a huge part of it is really just moving data and context from one site to another, and having humans look at unstructured data to try and generate some clinical decision. And that is something that we believe artificial intelligence and machine learning is a really positive use case for. I think there's elements of risk out there, obviously, and I want to be clear that at Cohere, we never use an automated solution to deny a case. All those denials, of which we do very few, are done by a licensed physician. But in terms of getting to yes quicker, I believe that artificial intelligence can play a really powerful role in extracting and transforming previously unstructured clinical data and clinical narratives into a form that can drive clinical decision-making and deterministic clinical decision-making. And that is kind of one approach that we've taken, where we're using a lot of the sophisticated rules really to just get us discrete data points, and then we feed them into a Boolean logic determination engine, and we can always inspect how the clinical decision was rendered given the inputs from that. And so utilization management, I think, is going to transform quickly. And I think Cohere are at the forefront of that. And really, I think it's not a question of if, but when. A lot of these processes will become transparent because of a drive to automation like this.
Definitely. Jason, your thoughts?
Yeah, just to kind of add to that, I think that where we see interoperability playing a key role here and a lot of sort of driving the machine learning enablement is through sort of key partnerships. We know that the groundwork around all of the implementation guides, all of the standards that have been in place are only as good as the amount of people using them. So facilitating data exchange to feed engines that are sophisticated enough to streamline these processes are really what will make these solutions scale. And the scalability of those solutions, ultimately the people that will benefit from it, we believe is the patient, is the person receiving the care in an expeditious way. So it will certainly transform utilization management, but we believe interoperability will continue to play a key role in enabling that.
Excellent. Thank you. In our chat, Roberta has a question. If you are unable to find all the documentation in the EHR, can you search the health plan for claims history, et cetera, to keep the process fully automated?
Yes, that's often step one in our process. If we can use the structured information that a health plan already has, such as claims data, it's kind of one of the most widely available data sets at a health plan. We will use that first because it's often a lot more easily obtained. And so we'll do different claims look back on those claims data for a given patient. But we'll also try to stratify patient populations and then also use that same claims data to do modeling on the provider as well.
Excellent. Thank you. Kathleen has a great question in the chat, and feel free to keep sending those questions in, folks. Here's the question. I know you mentioned how you are following state and federal regulations. In the state of Ohio, there's a state regulation that requires the use of an X12-278 for receipt and responses for all plans. I know DaVinci does have a translation process built into their IG to translate from FHIR to 278 and vice versa. Do you have this built into your process as well?
Yeah, we certainly do. Like I mentioned earlier, we were born out of sort of right into the FHIR interoperability world, so we were a bit spoiled and sort of getting exposed to the requirements very, very early on. But as we have continued to grow, X12-278 is not going away, so we understand that. And we also understand the need to translate that both in and outbound out of Cohere. So we do have a translation engine that facilitates the submission of prior authorization from X12. We utilize other methods to sort of hit that same sort of FHIR endpoint that can be accessible via a flat file, the HL7. So another sort of really interesting way that we sort of integrate with EHRs would be to listen to orders feed. So we try to take any sort of inbound signal that we can and translate it to that standard, because again, the standard is only as good as it is functional. So hope that answers your question, Kathleen.
Excellent. Yep, she said awesome. Thank you. Before I continue, just to let everyone know, the slides and the recording of today's event will be sent to all registrants afterwards. You guys talked earlier about all the benefits, and how AI will change prior auth and over the next few years. I want to talk about the biggest risks. What do you see as the biggest risks of AI in healthcare, and how are you addressing them?
Yeah, I mean, I think I pointed at this earlier on, but I can go into a little bit more detail. The risks of the utilization of artificial intelligence in healthcare have been talked about a lot, and I'll preface this by saying I'm a techno optimist about this, and I think all technology can be employed responsibly and irresponsibly. But essentially, it's not our intention to remove the humanity from healthcare. I think over the years, we've burdened practicing clinicians with so much administrative work that it's distracted them and demoralized them from the reason they got into healthcare in the first place. And I think, all of these different administrative processes were at some point probably well-intentioned and then became less so over time. And what we see the opportunity for, rather than saying like, let's just get rid of all these processes that we put in place, because a lot of them have some value. Let's just allow physicians to get back to the work of treating their patients and putting them at the center of their work, rather than the administrative overhead of practicing medicine in a highly regulated environment. And so we see the opportunity to reduce the administrative burden on practicing clinicians and allowing them to focus on patient care. Now, artificial intelligence can also be applied more irresponsibly. And I think there's a danger where asymmetries exist in the healthcare ecosystem, and whether that's a large health system interacting with a small regional player that doesn't have a lot of sophistication, or vice versa. You have a large national health plan interacting with a small independent practice. There lies the opportunity for misuse of the administrative processes. So, for example, it's possible for a large health plan to overwhelm a small practice with appeal request or with records requests, and that happens today. And then there are facilities out there that are using tools from the likes of Doximity, which makes it easy to respond to health plans in an automated way through the use of generative AI. And so really it's the intent of why these tools are being adopted. If it's simply just to overwhelm the other side with what used to take humans to write letters or to write appeals or to write record requests that now can be done in an automated manner, the intent there isn't to put the patient at the center of care. It's really to yield some power over the party that has a lower automation sophistication to gain some advantage, right? But if you think about it, back and putting patients at the center of the picture, I can see where artificial intelligence can really bring a lot of humanity back into practice, and not only that, but improve the quality of care. You'll have fewer physicians that are stressed with administrative overhead, and then you'll also have digital mechanisms to find where there are things that would have previously been buried in clinical notes can now be extracted and used for decision making that allows patients to receive much more high quality care and attentive care to all the aspects of their care.
Excellent. Jason?
Yeah, I think that machine learning and AI are, as we sort of continue to grow in the space, what we are learning is that it is the sort of assistant or the sidecar that is kind of going to enable the provider to get back to sort of what they are most interested in doing. So I think that the responsibility and the risks are sort of outlined in how the implementation of AI and machine learning will continue. So to Niall's point, a lot of it is choice, and choosing who to partner with is kind of key. But I think that the responsible method of implementing AI and machine learning will remain that if it remains sort of patient focused and provider enablement focused.
Excellent. Brittany has a question in the chat. Are you encountering any challenges with NLP when parsing unstructured clinical documentation?
I mean, there's always challenges with natural language processing. I will say that our use of more modern technologies, such as using transformer architectures and the same type of architectures that that run the services like ChatGPT and others, that has made the act of extracting and classifying kind of entities from clinical text a lot more understandable and a lot more kind of readily accessible. So traditional natural language processing techniques and models that have been out there for decades were never really tuned well to clinical language. And the other aspect of it is that clinicians often don't write in English sentences. They typically use a lot of coded language, whether it's, you know, abbreviations or literal, you know, codes, which trip up the traditional natural language processing techniques. But with the use of some of these more modern approaches, those peculiarities about the language of healthcare are surmountable. There's a lot of custom-tuned large language models, such as available from Google, that make this modeling approach more tractable, and we're certainly at the forefront of using those approaches.
Excellent. Jason, like to add anything?
Yeah, I'll just quickly add that it's important to underscore that unstructured clinical documentation plays a crucial role in sort of the clinical determination. But I think what I'm most excited about from the interoperability perspective is the attempt at standardizing what may be most difficult to standardize. So Niall alluded to sort of the complexity of medical language and sort of the complexity of the different methods of which EHRs capture this data today. We're excited to sort of really delve into what the FHIR R4 standards will enable us to do, enable us to sort of request very, very specific clinical documentation that we know we may need, whether discreetly or not, whether structured or unstructured. So it is certainly a challenge, but I think that there are many ways of achieving that goal, whether it would be through clinical documentation through an endpoint or just generic clinical documents themselves.
Thank you. I had a question for companies that have had previous issues with their prior auth vendor. How does Cohere approach the idea of collaboration?
Yeah, I can talk a little bit about that. We think that there's a lot of exciting work going on in this space. We think there are a lot of vendors and potential partners out there who are doing clinical data interpretation that is very meaningful to Cohere's use case, but we are a singular use case. So an open, interoperable platform is our end goal, is what we're working towards every day. And I think where we have facilitated those partnerships have been through a method of collaboration and reaching an ultimate end goal for our joint stakeholders. So as opposed to sort of looking at each partner working from each end of the spectrum, or looking towards sort of how data is submitted and where it's going, or who's on what side of the table, the proverbial interoperability table, it's more sort of focus driven or driven off of specific end goals that a partner may have. So Cohere has always sort of worked with very, very specific use cases for our payers, whether that be through pilot programs to achieve specific medical expense goals, or through sort of facilitating that sort of exact sort of project through collaboration. And that's sort of how we approach working with others, is by achieving very, very specific goals.
Great. Niall.
Yeah, and I just on the aspect of collaboration with our health plan partners, often we hear that one of the things that people like about Cohere is the fact that we are pretty transparent with how we run our operation. And so, whether it's a fully delegated offering where we are doing a lot of the clinical review and services work, or whether it's a platform as a service offering where a health plan is using our technology to run their operation, we're able to provide a lot of fine-grained analytics about how requests are being adjudicated, the timeliness of those requests, the kind of quality of the network of providers that are being serviced, and even looking into kind of trend management and forecasting of that with a lot of lead time, right? We're able to give a early trend analysis to our health plan customers. And so all of this isn't necessarily what was traditionally available from prior authorization vendors, but we really pride ourselves on, we are just trying to make the best clinical decisions for the members as possible, and here we're able to show our work in that regard. And so it's really a back and forth. We find that health plans often have really good insights about the provider network that they have, and about how they have traditionally handled different areas of clinical scope, and we're able to incorporate that into how we perform our decision making as well.
Excellent, thank you. Steve in the chat has a question. What kind of decision error rates have you seen? Decisions that are ultimately yes, but require a human to override the system's inability to provide the yes.
Just trying to parse that. Decisions that are ultimately yes, require a human to override. So, so the way we think about errors, I don't know if I'll be able to address this head on, but the way we think about errors is twofold, right? So for any given case that comes through the system, we first pass it through the decision engine, and the outcome of that decision engine can either result in kind of 4 different states: either a false approval, a true approval, a false append, or a true pend. And we track these data very accurately and very closely. So the thing we're most sensitive about is the false approvals. We do not want to approve something that shouldn't be approved. And so we naturally bias a lot of our models towards, if they're going to miss, if they're going to have an error, to do it on the false pend side. Because the idea being is that it ultimately goes through a clinical review by a trained clinician. And so even if we're wrong, the worst thing that's happened is we've momentarily delayed the decision. So I won't speak specifically to the rates of error, but they're on the false approval side, they're less than 1%. And when we compare that to manual approaches, we were able to, the machine is able to make decisions that are much higher quality. I think it's often is the perception that a human review is perfect, right? That humans never, they follow guidelines, they never make mistakes. But we're able to see from our data, and remember, we're scoring every case. And so when we pen something for clinical review and it gets approved, and we thought it had a very low probability of being approved, we can take those cases and audit them, both clinical audits, sending it to medical director for further inspection, or with our own artificial intelligence and machine learning teams are very sensitive to errors as well. And so they look at each and every error that the model got wrong and try to explain what was missing and why so. So there's a pretty large operation behind each of the clinical programs to ensure that that we minimize false approvals and then drive down any false pens. And so we're trying to drive into those two true approval and true pen categories.
Excellent. Jason.
Yeah, I think that as Niall mentioned, we monitor those very, very closely. Along with that, those error rates, there's a lot of sort of our success rates around how data is exchanged. So how data is being fed and what that ultimately leads to, we see going 1-to-1. But I mean, I think Niall said it pretty well. It's through sort of proactive monitoring and reactive responses to those error rates that will prevent them moving forward.
Excellent. Thank you. If there are no other questions in the chat, I'll leave you with this last final question. What is your vision on how clinical data interchange can best be managed or interpreted regarding the Cohere use case?
Yeah, so this is a topic that I think we are very, very interested in pursuing and seeing how it grows. So clinical documentation exchange, whether it be through regulation like TEFCA, whether it would be through the CMS final rule, we see as the sort of next frontier of sort of how information is being shared between health systems and healthcare stakeholders. So being able to get ahead of that and parse information in any manner, like I mentioned earlier, but also having the wherewithal to manage requirements from a given party, whether that be the payer or the requirements from a provider, and interpret that through a machine, and being able to retrieve that from a given source is sort of where we see the kind of frontier of clinical data interchange going. So it's about standardizing requirements in a manner that is interpretable, is manageable, and also retrievable through any other source that we may be getting that information from. So the DTR use case that we see being implemented, components of it like CDEX are sort of just really starting to grow and get traction, and it's something that we are actively working with partners on to grow and enhance on the Cohere side.
Excellent. Niall.
Yeah, I don't have a lot to add to Jason's summarization there, but one thing I would love to see in terms of greater clinical data interchange is a proliferation of the clinical query language spec. So that's something that's been outlined in FHIR and Da Vinci. And really, I think with the advent of a lot of the large language model interpretation, I think we have a shot at really creating a robust and structured way of querying clinical data from a variety of different repositories, whether it's a health plan exposing a clinical query interface, or an EMR, or a vendor like ours. I think that's where we can see a broader reach of interoperability. Because as I said previously, the standard Da Vinci APIs, CRD, DTR, and PASS don't necessarily get you all the way to an automated and a touchless prior auth. With clinical query language, when you map that directly to guidelines, that's when you can start to get to an actual touchless determination, provided that the repository of data exists and is exposed via a clinical query language interface. So that's really my hope, and hopefully to some of this audience that may be an inspiration.
Excellent. And this was a very informative and inspiring presentation. Thank you. Niall O'Connor, Jason Amaral with Cohere Health. Greatly appreciate the work that you're doing and being a part of this WEDI virtual spotlight. Thank you very much once again.
Thank you all.
And everyone, thank you so much for this, for attending this informative presentation by Cohere Health. On behalf of WEDI, thank you for being here. Happy holidays, and please visit wedi.org for more educational opportunities.
I know.